welcome everyone to the Delaware American Academy of Pediatrics Justice, Equity, Diversity, and Inclusion Committee's webinar on suicide prevention and understanding the landscape and tools for identifying those at risk. I'm Dr. Kilgallen. I'm actually a pediatric anesthesiologist who chairs this committee. And today we're going to have Dr. Deb introduce our speakers, two amazing speakers from locally, Delaware, as well as more internationally in terms of Columbia and her reach, Dr. Posner and Dr. Hofses. So Dr. Deb, take it away.
Good afternoon, everyone. And so today we are doing our second webinar for the Jedi community. And the topic is basically suicide prevention, understanding the landscape, and the tools to identify those risks. We have two amazing speakers with us, Dr. Hofses and Dr. Posner. I will talk about Dr. Posner first. I'm pretty sure a lot of us who are in that knows her by the name, and we are lucky to see her here today. So Dr. Posner is a professor of psychiatry in Columbia University, and her work is saving lives all over the globe. So she was former president of American Psychiatric Association, and noted her work with Columbia Protocol could be like kind of introduction of antibiotics. That's how it is said. And Dr. Posner, CDC noted her work to be as changing the paradigm of suicide risk assessment in US and worldwide. Dr. Posner's work has been noted as a keynote speech in the White House in the congressional hearing, and she gave a lead presentation in the US Senate Forum on school safety after the Parkland. Dr. Posner has recently been appointed chair of Governor's Veteran Suicide Prevention Task Force in New York, and the Columbia Protocol is the policy across 50 states, national agencies, and most countries. And the FDA characterized her work as setting a standard in the field. Her scholarly work has been included in the compendium of the most important research in the history of the study of suicide, and she was recognized as one of the top 20 most influential scientists from Columbia University across all areas of medicine over the last 10 years. So Dr. Posner has been awarded the Secretary of Defense Medal for Exceptional Public Service. Thank you, Dr. Posner, for being with us here today. And we have Dr. Catherine Hofses. Dr. Hofses is a pediatric psychologist and clinical assistant professor of pediatrics in Sidney Campbell Medical College, Thomas Jefferson University. She is a psychologist in Nemours Children's Health. Dr. Hofses is director of psychology externship training at Nemours and is a member of psychology externship internship training teams. And so her passion is integrated service delivery in primary care, psychology training, and enhancing physician competence and efficacy for addressing behavioral health concern. So welcome, Dr. Hofses. So Dr. Hofses will begin our webinar with her talk on suicide prevention, understanding the landscape, and followed by Dr. Posner, providing the best pediatric care, embracing routine risk detection with Columbia Suicide Screening Protocol, reducing the risk in our youth, and redirecting scarce resources and liability protection. So we have no disclosures.
Thank you so much, Dr. Deb, and for everyone here for inviting me to participate. I'm really excited to be here with you all. Again, my name is Katie Hofses. I'm a pediatric psychologist at Nemours Children's Health in Delaware Valley. To represent some of my positionality, my preferred pronouns are she, her. I'm a white female, cisgender female, and again, presenting as a pediatric psychologist in integrated care today. And just want to thank my colleague, Dr. Kumar, for inviting me to participate. So thank you. I'm going to present a bit today just to give a brief introduction about the landscape for what we're seeing in terms of child mental health across the United States to hopefully lay a foundation for what Dr. Posner is going to talk about surrounding screening. To give a bit of background information. So what we're seeing is that roughly 1 in 6 children ages 2 to 8 are annually diagnosed with mental behavior or developmental disorders. We see that amongst this population, boys are more likely than girls to have mental behavioral or developmental disorders. And to give a bit of a spoiler to some of the information that I'll present today, those that are living below the poverty line, we see that these numbers increase. Those that represent or from minority backgrounds below the poverty line, we see that more than 1 in 5, so about 22% are diagnosed with mental, behavioral, developmental concerns, and that age, along with poverty, not only affects diagnosis, but also the likelihood that children will receive treatment. To look at this slide here, we see just that younger children, as might be expected, are presenting with behavior issues. And then as they age, we see a higher frequency of depression and anxiety concerns. Throughout the time span or throughout that age span, we see consistently that about 1 in 6 experience a mental health disorder every year. We also know that 50% of all lifetime mental health illness will begin by age 14, 75% by age 24. To compare some statistics for what this looks like for young children in Delaware. So when we think of young children, we're thinking of those from birth through age 5. We see these Delaware statistics. So about 17% of children birth to 5 in Delaware are living in poverty. As children get a bit older, so those 3 to 5-year-olds, we see that about 8% are being diagnosed with developmental delays or disabilities. And then in that same age span, that 3 to 5-year-old age span, we see that about 49% are not enrolled in school. When we look at young children living in poverty, we see that this number grows to being about 60% that are not enrolled in some sort of preschool, pre-K program prior to the age of, prior to starting kindergarten. When we further look at the landscape here in Delaware, we look here at the percentage of children in Delaware who've experienced 1 or more ACEs, and ACEs by age group. When we talk about ACEs, we're looking at traumatic events that occur in childhood. Why we're concerned about these is for many reasons, but we also know that traumatic events that leads to toxic stress, prolonged activation of a stress response system. And we also know that children with more ACEs are more likely to show negative long-term health and social outcomes. When we think of the different categories that these might fall into, so here we're looking at things like physical, mental, sexual abuse, neglect, and also things like household dysfunction. So, for example, having a family member that's incarcerated, a family member who is managing substance abuse, violent treatment of mothers, things like that. So certainly seeing a large percentage of Delaware children affected here. And I think in recent years, so first in December of 2021, and most recently in the spring of this year, our Surgeon General noted that a mental health crisis, or brought attention to the youth mental health crisis. I'll talk a bit in a slide here, but I think if anything, it was just drawing attention to what we in practice see so often. And the note here, right, that a youth mental health crisis was already brewing and that the pandemic made it worse. As we look at this slide represents the CDC's Youth Risk Behavior Survey. This looks at data from 2021 and draws on 10-year trends. So we see information starting back in 2011 all the way up until 2021. This is the first data that looks at some of these things after the pandemic. So here we're able to draw some inferences, again, over that 10-year time span to look at trends. This looks at behaviors and experiences among high school students in the United States related to health and well-being. And so as you can see here, What this data shows is that many of the same behaviors and experiences that were noted to be concerning before are continuing to move in that concerning direction after the pandemic. So as we look at some of these variables, if you look at these stop signs, so you see the percentage of high school students who report persistent feelings of sadness or hopelessness, those who report experiencing mental health concerns, those who also note seriously considering or seriously considered attempting suicide, having made a suicide plan, as well as attempting suicide. This is all trending in what we could consider a wrong direction, right? So these numbers are getting higher. That one question there, experience poor mental health, that had not been asked prior to 2021. So we don't have the same trends that we have early on for these other questions, but still see a very concerning number there, right, for 29% of high school students. And so nearly all of these can be considered indicators of poor mental health. And again, these percentage of students who consider these things is just increasing in a wrong direction. Why we might be concerned about this, right? So I'm sure is not new information to anybody, but poor mental health can result in negative outcomes, not only for health, but also development, which can certainly persist into adulthood. As we look at these trends a bit more closely, we see that the percentage of students across every racial and ethnic group who felt persistently sad or hopeless increased. The percentage of female students who seriously considered attempting suicide, made a suicide plan, and attempting suicide increased. Black students were more likely than Hispanic or white students, Asian, Hispanic, or white students to attempt suicide, and LGBTQ plus students who had any same-sex partners were more likely than their peers to experience poor mental health, suicidal thoughts, and behaviors. So kind of in sum here, those from minority groups, young people who were already having emotional difficulties seem to be harmed quite a bit more by the pandemic than some of their same age peers. As we look at some of this data as it relates to suicidal behavior, suicide is the second leading cause of death for those 10 to 14, as well as those 20 to 34. We know that suicide is really just the tip of the iceberg, right? So for every suicide death, there's roughly a number of hospitalizations for self-harm, a number of emergency department visits connected to suicidal behavior, a number of suicide attempts within the past year, as well as a large number of those who are seriously considering suicide. And so I know this slide here has a lot of information, and hopefully this will get shared amongst others, but again, can see those minority populations experiencing suicidal behavior, attempting suicide more than some of their peers in that way. We see that those suicide rates vary by race, as well as ethnicity, age, as well as other factors, such where someone lives, those who live in rural areas, again, those who identify as being lesbian, gay, bisexual, have higher prevalence of suicidal thoughts and behaviors compared to peers that are identifying as heterosexual. And I'm just going to keep moving here. So then there's been question of what's caused these changes. Why are we seeing these increases? What seems to be going on here? And with the methodologies that we have, we really do try to account for some of these things. Account for, gosh, is it that our time's harder than it was 10 years ago? What's really changed for kids today? So we do try to control for that. Is it folks that are teens are talking about their thoughts or their feelings more? But a lot of these things, I will say, have been around for some time, right? School shootings is not something that's new. Access to phone and social media, certainly political, economic strife, some of these things are not different. So what we are seeing is just higher rates of depression and anxiety. And again, we can point to some of these trends as rising steadily prior to the pandemic. Just to give a word about social media, right? So I think what we're also seeing is that social media tends to amplify what somebody may be experiencing in real life. So, for example, those that have good friendships, that often carries over to how they interact on social media. For those that feel isolated, those interactions on social media can make them feel worse, right? So in some ways, it's great to have a call to this, a call to raise our attention to factors such as loneliness and social isolation so that we can hopefully attend to these things more readily. Um, we also know that mental health is shaped by a number of things. If we think about our biopsychosocial model, right, we know that society, environment, community, family, as well as individual factors can influence how mental health looks for our young people. And as I get to the end of my portion today, I hope not to leave with this great sense of doom and gloom, as I would imagine that, again, I think that none of this might not be necessarily new information to the providers that are here. And just want to have a call and also have a thank you because for so many children, pediatricians, medical providers are really the first advocate for child mental health services and support. So the work that you're doing is really tremendous. And I know that it's confounded by limited time and resources. And so as we studied adolescent mental health for decades, we know that the single most powerful force for adolescent mental health is strong relationship with caring adults. Their need for connection, their need for meaning, to feel purposeful, that really helps them thrive, not just in the short term, but also in the long term, to think about creating the kind of adults that we want to have in our society. And so, just as we know that those feelings of loneliness and isolation are such a key predictor in depression and suicidal ideation, we really want to lean into this of making sure that every teenager is connected to an adult that cares for them, that gets them, and understands them. This is certainly something that we can all do. So this doesn't need to be a parent. This doesn't need to be a teacher. But can really be, one of us that we see in our practice. So would just encourage everyone to try to think about how we can foster those strong relationships with our patients. Some other words, certainly encouraging positive sleep routines as well as positive, healthy routines. I think of sleep and positive routines as really the glue for so many. And that without those things, it's just, again, makes life a little bit harder. And so also thinking about how we can support positive habits like exercise, in-person activity, as well as connectedness through our schools. Just other words here about how healthcare systems might be able to help as well. I know Dr. Posner will talk about screening for mental health problems and risk factors, but also going to think about how we can focus on prevention as well as trauma-informed care, addressing mental health needs of not only patients, but as well as their caregivers, forming community partnerships, as well as noting that multidisciplinary integrated teams are really a critical component to addressing the mental health crisis that we see. Certainly this is not done by medical physicians or by psychology alone, but thinking about deep interdisciplinary teams that can support our work, as well as looking at provider burnout as well. And so then just as a final piece here, some resources and tools. These are all meant to be very practical strategies to be helpful, resources and websites that can help strengthen our skills as providers, but also giving parent-friendly materials there. And just a word at the bottom here, if anyone finds themselves commuting quite a bit or taking information in through podcasts, one that I really like is that by Lisa DeMar. She's a clinical psychologist and really an excellent advocate for adolescents and seeing them as their whole selves and really recognizing the wonderful beings that they are. So we'll just say a word there. But thank you for inviting me today, and I hope this was helpful.
Dr. Posner, you can take over.
Yep. Okay, so So, this landscape was already started to be set, but what is the biggest health problem we have? It's not heart disease or smoking, it's depression. Number one cause of global disability. Just to put some numbers to that, we estimate that 264 million people are living with depression versus 18 million with cancer. Okay. And we know that at least probably, I used to be the head of diagnostics as well, 20% of teens meet criteria for depression. Okay. And suicide is not a problem of youth or elderly or veterans. It is our shared crisis of humanity. But the very, very good news is that we know this is our one preventable cause of death, despite the fact that it's been this tragic paradox that takes more firemen than fire, more police than crime, more lives than car accidents. So here's the good news, or so we thought, okay? After 20 years of the suicide rate going up each and every year, in 2019 and 20, even during COVID, we had our first reductions, 6%. But guess what? That reduction was only among white Americans, where we were still seeing crisis, and new crisis was among our most vulnerable and minorities. And then in 21, it went back up 4%. And the biggest reason for that rise were males 15 to 24. Okay. We're going to, talk about how that barrier to help seeking is much, much higher in boys in your practices and in men, right? So, for example, there's one statistic that girls going to the ER for mental health reasons has gone up 50%. That might be good. They might be help seeking, but only 4% in boys, right? So we really have to break down those barriers. And one of the ways we do that is through making this routine and normalizing. And now in the last year, we've seen an increase again, but youth went down 8%. So, I was gonna say, for every depressing statistic, we have very, very much hopeful counterparts. And like I said, minoritized youth in particular. So it's now become the leading cause of death in Asian American Pacific Islanders age 15 to 24. Did you know that the CDC told us that 5 to 11-year-old suicide has increased, but only among Black preschoolers, okay, and Black young kids? And we're going to talk about what we need to do to address that. And if you have more than one vulnerability, right, you're AAPI and LGBTQ, then, the rates are even higher, as you would expect. AIAN, 10 to 24, nearly 3 times as high as their peers, okay? And we know everyone's touched. 135 people are affected by every death, and these effects linger across generations because of that silence that often follows. And we're not alone in that. I work with every nation. In Ukraine, you can't get buried. A priest won't bury you if it's a suicide. We had a signing ceremony with the Kingdom of Saudi Arabia, this all-female university. And, World Health Organization says, countries that condemn suicide, they won't report even because of the consequences. But they're like, now to even admit there was a problem, and this is bringing us out of the light, which is what we're going to be talking about. So I don't know, many of you may be familiar with the Columbia Protocol, and it's really policy across the continuum of care, across all these states. But one of its main reasons for being has become a vital part of wellness for employees and their families, right? If we're not taking care of ourselves, right, you can't do the job you need to do to save the lives of the people, the kids you're trying to serve. So I don't know if you know, but if you take a large corporation of 100,000 employees, every 6 days, an employee or a family member will die by suicide. So if you look across these 50 states, okay, when the policeman or the fireman is doing it, they're not just doing it in their job. They're doing it to save their own lives and their families' lives. And I don't know if you know, but there's an app you can all download on your phone, and all 50 states have it. And some states, it's being customized. But when the Department of Homeland Security, they made their own app, right? So if you're Secret Service or TSA, it connects to their EAPs. But the articles were like, this is like nutrition and physical fitness, right? When you start to treat suicide prevention like wellness, that helps us save lives in in an even more potent way. And I went on CNN a bit into COVID, and American Medical Association called up and said, yes, of course we know the Columbia, but how do we get it in every health professional's hands? Did you know it's the #1 cause of death in male medical residents and in nurses often? So last year in Physician Prevention Day National, at Columbia, all 10,000 residents got these cards that I'm going to show you in a second, but also kids, right? I went to Sloan Kettering to give a talk because this is like blood pressure, and the head of nursing said, I used it to save my son's life. And we hear that 1,000 times over. So this is a mechanism not only to prevent burnout and care for yourselves, also families and communities. And this minoritized risk, it's also in the workforce. Did you know that Black male physician suicide is double the rate of white male physician suicide? So you're from Nemours, right, Katie? So this is an example, right? Ask your fellow resident, ask your colleagues. You can all get these, right? And it's got the Nemours Employee Assistance Program on the back. Everybody in the institution can have that little lanyard or an app, right, to take care of, and family members. This is an example from Homeland Security. They give it to all family members, like other EAP resources like dog walking and childcare. And of course, we know this doesn't discriminate: rich, poor, Black, white, celebrity, or teacher. And guns, right? This is the communities and the youth that you serve, what this crisis has meant to our nation. Did you know that 2/3 of gun deaths are suicides? And sorry, somebody, 2/3 of gun deaths are suicides. And I always say that guy who goes up to that gun counter to buy that gun does not want to die and does not know there's help. So we've been working with the gun community for well over a decade. And how does it connect to gun violence prevention? 90% of shooters have suicidal issues. So I said this back at Columbine: let's screen and find people who need help before it's too late. So President Obama's Deputy Secretary of Education said these questions can keep our 64 million children safe. Parkland, Stand with Parkland, they talk about the Columbia as much as they talk about guns because they want to get upstream, right? And we know we need to get upstream as much as we possibly can. And that gun shop worker does not want to sell the gun to somebody who's going to hurt themselves or somebody else. They're not going to ask everybody who comes in, like you should do in primary care or in the schools. But if something feels off, they will have something and want something to do something about it. Look, police are using it as the criteria in their risk protection orders to determine who should get a gun, who should get a license. And we should, of course, be doing this all over the nation. So one of the reasons, importantly, that the Columbia has become the global standard is because it's the first time we have evidence-based thresholds for who's at imminent risk. Right? Before, we didn't know who to worry about. So that policeman had to take everybody to the ER. That kid had to sit in the principal's office. And this has been really a game changer. And what's really nice about the Columbia is that it's proscriptive enough for the non-professional, the ED triage nurse, the policeman, the parent, but then flexible enough just to inform a provider's judgment. And I don't know if you can see on the side of the screen, that's from the app. And you know what it says? It says if you get a low or moderate answer, a mental health referral may be helpful. That is so important because the only thing you should treat like crisis is crisis, right? The only thing you should treat like high risk is high risk. When you treat a moderate or a low risk like a high risk, you know what it does? It shuts them down from treatment when they actually need it. So this is very algorithmic, and you'll see the liability protection is related to unprecedented science, 600 studies, 50 predictive. But the icing on the science cake, I like to say, is the ERs out of Sweden. It predicted death by suicide. Do you know that's never happened in the field before? Just really reinforcing this particular method as just being vital. And we're here to talk about youth. You know how there are these national guidelines: screen for depression after 12, screen for anxiety after 8. Don't screen for depression, for suicide at all, as if some kid is going to magically come tell you, right, that they're suffering. Of course, that's silly. I dare say ridiculous. Look at this data. 6 to 12-year-olds had the same odds of being identified as high risk on the Columbia as 13 to 17-year-olds. And screening did not increase ER length of stay. Of course, we need to ask everybody and do it routinely. Right. And we know that what this does is it screens, triage, and identifies high risk all in one. And the data to support it, so the game changer, the first question that gets you into high risk is intent to act. Okay. Look at this data. Oh my God. One of the studies of the many, 1,400% increase. So we know that's the game changer, not methods, but intent to act. And then 5 is an intent to act plus plan, but just to show you, the potency of the particular questions. And what is the high cost of not getting as upstream as possible? And when we're talking about suicide prevention, it's not about money, but when it's all resources are going in the wrong place, you can't do what you need to do. But look what happens when you do something about it. Did you know that Centerstone is the largest provider of outpatient community healthcare in the United States? They reduced suicide 65% in the first 20 months, while they reduced emergency department recidivism from 40% to 7%. And you'll hear all these examples of, millions of dollars being saved. It's not about that. It's about when you have that 40%, and all that noise, you can't do what you need to do. So lots of examples, 50% reduction in 1 year, et cetera, et cetera. And we know with minoritized populations, it's even worse, right? Black and Latino, over 3-hour wait times in the ED. It's so critical to be able to deal with these resources in a much more efficient way. Do you know that only 1% of people get a high-risk answer on the Columbia? So it redirects whatever resource you're talking back to where they need to be, right? And we know schools, 61 to 97% of referrals do not require that level of containment, cost, and care. And that going to an ER when you don't need to is costly, traumatic, and less effective in getting them where they need to go. Pretty much every state has policy with the Columbia for schools. This in Connecticut, this is an example, it's legislated. But look, they talk about the same thing, inappropriate ED utilization, and that traumatizes kids, right? So this is one of those kind of all upside ways to avoid that. So now watch this little video.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself. So I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to CSSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm going to ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that. All right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
So this is analogous to what you can do in your practices too. That young woman definitely needs a referral for treatment, but she doesn't need to be taken to the ED hold room where she's going to be just sent away. And he has an algorithm. She had a wish to die, which is the lowest risk over 20 years, right? And a moderate risk with the behavior. And that policeman doesn't want to take somebody to the hospital that doesn't want to go. And you know what the science shows us? That people who receive the lowest level of care in the community have better outcomes. They ask for help more often, and they have a better quality, of life. And so I told you that Centerstone example. They brought this to life by telling a story about this guy who they called a few times and he said he was fine. He said, the last time you called me and asked me those questions, I was on the bridge. The power of asking beyond the doctor's office. And you know, when EMTs use this, it increases voluntary hospitalization. That's what we want to do. It's also, we know with universal screening, it's increased mental health follow-up and treatment engagement by 60%. Okay. And the Cherokee Nation said it really well. Its ability to risk stratify allows you to improve access to services and triage your wait list better, whatever those services are, you know, whether it's, you know, food banks or transportation. And this is one of the most important concepts. You know, I probably don't need to tell you this, but over 50% of people who die by suicide have seen their primary care doctor the month before they die. 2/3 of adolescents who show up to the emergency department who've tried to take their own lives are not there for psychiatric reasons. So we know we need to use this routinely, or we will not find the youth suffering in silence. But here's the big caveat. We have to have that concept well beyond the doctor. You know why? Because many people never get to the doctor. Okay. So the teacher in the school, it's the #1 cause of death in construction workers. So they say the safety check in the morning should be more than the hard hat. It should be the Columbia. You know, universities and schools have said for a very long time, the coach, you know, the janitor. We're going to hear all these stories, and routinely. And you know what? As Katie, you mentioned, you know, when you universally screen, you know, it destigmatizes, and people asking and being asked feel more comfortable. And it may sound, I don't know, corny or something, but Israel said, you know, it's not just saving all these lives, it's changing the way we live our lives. If you can, by breaking down barriers that have been built up over thousands of years, if you can talk about suicide, you can talk about anything. It gives us voice. And that's what it will do and can do for these other marginalized communities. And we know that the majority of youth will not actively seek help from professionals, parent, teachers, and oftentimes not even peers, which is why we have to routinely go out to them. And we know that school personnel are one of the most vital places to identify ideation, and they also become the protective factor to help mitigate risk, right? And so we know when we're dealing with minoritized and marginalized youth, that they won't go to traditional office-based mental health. So we have to set up, you know, creative partnerships with rec centers, community-based organizations, schools, churches, etc. And, you know, this is one of the other empowering things I'm going to tell you. It's so important for everybody in your community and in your building to be part of the solution. You know, I gave a talk for a state many years ago, and this huge system said, you know, we gave it to the janitors. And this clinician said, exactly right. I'll never forget that vet who only spoke to the janitor. In Vermont, they have policy in schools for janitors and custodians. Look at this, a front desk staff member. This is zero suicide out of Connecticut, right? Saw someone not looking good, knew it was okay to ask, you know, transported to the care he needed. I went to Jackson Memorial, you know, the big system in Miami. And you know what they told me? The engineer was fixing the light bulb in the patient's room. And she started talking to him. He knew about the Columbia. He asked, he called the provider. Every single person can and needs to be part of the solution. And we know, okay, that, you know, if PCPs say they have knowledge of this, they're 5 times more likely to screen. And routine screening for mental health is more frequent in urban areas, right? And this gap continues to widen. And we know we need to do something about it. And we also know, right, like I said, within a month of attempting, but where you're going to see the boys in the ED or primary care settings, it's very, very important. And we also know, of course, that pediatric patients with chronic illness have higher levels of suicide risk and depression and anxiety, right? And we know that healthcare providers see this screening as positive for both their patients and themselves. And we have this toolkit. You can get this later. This is the risk assessment version that can go give you a deeper dive with all the risk factors that apply to this. So what were the barriers? You know, that liability was one of the biggest ones. We don't have a perfect formula. We may never have one. How can I ask? So malpractice attorneys have written for a very long time that if you ask these questions, it protects you because it has more science and because we have a responsibility to ask. But look at this, not just in healthcare. When MIT had a suicide, like every university, the Supreme Court brief wrote about it as the reasonable standard. What does that do? That frees up the teacher, the parent, the roommate to be able to ask without that barrier. And I have to tell you this, I was helping this school, university, with this case. I'll never forget the story. This roommate woke up, her roommate was fully made up at 6 a.m. in the morning because she knew she was going to take her life shortly thereafter. And she knew there was something wrong, but she didn't have something to do about it. So, this story today is really about all hands. It's also helping, reduce force when police are using it. It's used as a de-escalation tool. It is used as a liability protector, which is why police didn't want to, had to take everybody before. And we also know, Katie, you spoke about connectedness, and the CDC tells us it's one of the major things we need to do to prevent suicide. And a common language also can be an intervention in and of itself, right? It builds cohesion, it builds connectedness. And we know that school connectedness is improves, educational and health outcomes. And the Columbia is more than just a method to identify risk. It's a framework for normalizing, the tough conversations and reducing stigma. And as you said, right, young people who experience youth adult school connectedness, they have better health outcomes. They actually have reduced better mortality, right? We know how important this is, and this is a mechanism for just that. I don't know how many of you have heard the story of Kevin Hines, who survived jumping off the Golden Gate Bridge. And he was 19, woke up and said, if just one person asks me if I'm okay, I won't do it. What's wrong with that kid? Goes to the side of the bridge. This woman walks towards him. He becomes hopeful. She says, can you take my picture? And he said, screw this, nobody cares. And he jumped. And as he jumped, like every other survivor, all he wanted to do was survive. And he says, people considering suicide want someone to save them. What we need is a culture where no one is afraid to ask, right? And by the way, he gets down in the water and realizes he's alive and feels something slimy, says, oh my God, I just survived jumping off the Golden Gate Bridge. Now I'm going to get eaten by a shark. Just my luck. So he's on a show a few months later, and this guy calls in and says, buddy, let me tell you, it wasn't a shark, it was a sea lion who kept him afloat. And I was on the phone, all agencies use this pretty much. And I was on the phone with the head of an agency that helps sex trafficking victims. And she said, I was a victim of sex trafficking. And I can't tell the humanity that was taken from us. And I tried to take my own life. And she said, I believe if we had had this, I wouldn't. I only tell you that story. It's not that people are okay with being asked. They're desperate to be asked. Okay. They want to be asked. And that, unlike that clinical lore, you can intervene at the last minute, and 93% of people will never go on to try again. And so we do that everywhere around the gun lock. Like I said, Parks is putting it every ledge they can where you see on the Grand Canyon. I hope you're going to see it soon when you go to that, because everywhere there's methods, we can have this method, in that full-on public health approach. And, the Miami Herald called me up because these two suicides, these kids jumped off the roof of the school buildings. And they said, we called the state, they do it in the nurse's office. No, we have to get much more upstream, right? And so we already talked about this, lots of redirection of resources. And what's the other reason that the Columbia uniquely is the global standard? It's the first time we're getting at the full range of behavior. What does that mean? It means in the past, you would be lucky if you got asked about a suicide attempt, and then you miss the kid who wrote the note or collected the pills, right? And we know we can't afford that. Do you know that represents 87%, these other behaviors? And look at this, an interrupted attempt, when you grab the pills out of the kid's hands, 4 times as predictive as an actual attempt. We know that every shooter has written a note. Just very quickly, I do a bunch of talks with the Parkland survivors, the ones that lost their kids. This is an FBI report that studied 67 averted attacks And their major findings were that this is preventable when we ID as upstream as possible, okay? And students are best positioned to identify behaviors. And so we must create school cultures and community cultures where they are comfortable and rewarded seeing something and saying something. And the earlier, the more likely they'll say something. If they think somebody already has a plan, they're like, oh, he probably doesn't mean it. I don't want to get him in trouble. This is also one of the most important things that I can tell you. Do you know that 80% of kids and people in the United States around who end their lives do it in their homes? 95% of 5 to 11-year-old Black children who take their lives do it in their homes. Okay. So, you know, when I got to give that lead presentation to the Senate after Parkland, and I said, you know, you all have policy for the doctor and the policeman. How do we get in all parents' hands, right? And all coaches and all teachers. And you can see this is what pretty much most states like. This is just an example from Colorado, but you know, 5% natural, 5% playground, right? So if we have a full-on public health approach, we will do a better job finding at-risk youth where they work, live, learn, and play. And we know that's so critical. Do you know that we know that having a public health approach is the way that we will find people at risk, because as I keep saying, they don't get to the doctor. So you see all these examples across these states, theater workers, you know, coaches, et cetera, et cetera, et cetera. And we know that when we universally screen, we know that we have better outcomes. Okay. So, I just want to tell you this quick story. That's Ryan Petty, was sitting next to me, who lost his daughter at Parkland. And you know that after you have a mass trauma, the risk of contagion goes up. You might recall that a year after Parkland, there were, increased suicides, so we did all this media about this, and we're all accountable. We have to put it everywhere. And this kid called up Ryan Petty, who was at Parkland. He went to University of Utah. He did the Columbia. He was high risk. They called the crisis line. He then took his phone and called an Uber from Parkland, Florida, to pick him up at the dorm in Utah, brought him to the hospital. The simple life-saving potency of that, and we can do that 1,000 times over. By the way, when I mentioned the app earlier, the White House highlighted the app, and it went to all state legislators as central to what we all can do to prevent suicide. And we know, right? You showed the YBRS data. We know that a large portion of kids, and we know these are gross underestimates, by the way, before we have better, more comprehensive monitoring. And so when I'm working on policy with your states or any other, we think about how do we get it in every home, in every backpack, in every family member's hands. And we know that with, again, minoritized, youth and marginalized youth, it becomes all the more important to find them in that way. And this is what your states look like, you see, across the continuum of care. And look at this one example right out of Connecticut. The policeman has that sticky pad with the QR code. 4th grader, mobile crisis confirms, gets to the hospital. That more timely intervention was dependent upon that common method of detection. And I know we only have 6 minutes, so I'm just going to make sure there are no particular points that I want to make. But this is, across the world, the same thing, right? And a nation identifies a problem, they do a study to address it, and that gives us this huge scientific foundation to support this public health work. And you talked, one of the reasons that people don't get the simple care they need is because of that stigma, right? This isn't a real illness. I'm weak if I ask for help. What does 13 Reasons say, right? It says the opposite. It says this is a rational choice, not a brain-based illness. Do you know that the suicide rate increased the month after its premiere? Right. So we know that misunderstanding can literally be lethal. And again, we're going to get you all these slides. So, you can have them. And we know that in boys, again, the risk, that help-seeking barrier is much, much higher. And the more we make it routine, the more we will break down that barrier. We also know that we must have this common method. This is what they call the blood pressure cuff. You know, if you had more than one blood pressure cuff, you wouldn't know what your blood pressure means as well as you should, nor would your doctor. This is the CDC document. You'll see the CSSRS, but also the unacceptable terms, the terms we shouldn't be using anymore.
I couldn't be more pleased.
And
to
then
talk-
I'm going to just say, and the Joint Commission says the same thing. We all need to be doing the same thing. That helps us find the kids, the needles in the haystack, right? And peer-to-peer, oh my gosh, the data shows it's the most helpful thing we can do. And it increases hope. It improves quality of life. And so we really, Amazon says they might put it on the side of the bus. We have to think about a public health campaign the way we did with smoking and seatbelts, right? Because that's the most important thing, to get this as upstream as possible in people's hands. And I spoke about that silence. You know, at one point in history, learning to wash hands began saving lives, and now this can really build resilience across generations. And the Parkland survivors say also, as a community, we don't have to sit back and feel powerless. We can feel like we're part of the solution. So there, now we have about 5 minutes for questions. So thank you.
Dr. Hofstas and Dr. Posner, thank you so much for coming today. Dr. Deb is going to lead questions for about 5 minutes. We know we ran a little bit late because of just the rocky start in the beginning, but just as when I saw Dr. Posner present at the Region 2 NMA conference, I said, we've got to get this out there to as many people as we can. And given that I serve children in Delaware as an anesthesiologist, I figured this was the best way to do it. So Dr. Deb, if you could just, for anyone who has to go, we understand, but if we can at least have about 5 minutes of questioning, that'd be awesome.
Yeah, I don't see any question in our chat or Q&A. So if any of the participant has a direct question, maybe go ahead and ask that. I just see a comments. Obviously, there are thank you comments, and there one of our participants reported that a friend's son committed suicide 5 days after seeing the primary care doctor and after having a suicide screening. So
yeah, but that's the thing. We don't know what the screening was, you know, and again, we have to do all these things. We have to again have this public health approach, and what we all can do, right, is get this to our communities on Instagram. You know, what we find is that I showed you all that top-down policy, but when we have bottom-up community efforts, I'm talking about, you know, peers, parents, everything, the more we can do that, that gives us the most potency.
I have a question.
Sure.
At Maryland AEP, we created 2 suicide prevention videos where the teens were telling the parents that they needed to ask them if they're worried, and also teens telling other peers. We have published them to our website, but getting them into pediatricians' offices is like the conundrum. Since you've done outreach to get them this into it, like what would you suggest as an approach to get the videos into the right people's hands?
You know, I mean, first of all, if you could send those to us, you know, because if you know, we can put it in our package, you know, sometimes tagging along to something useful. And also, I would, if I were you, I would also look at the video with the teen, with the Columbia specifically, that you might want to also, make use of. But you know, that you know, it's about marketing, and it's really about, you know, maybe again hooking onto these larger reach things.
Yeah, our intention was for the QR code to be available for the parent and the doctor to say, hey, at a well visit, hey, why don't you watch this video while you're waiting for the doctor to come in? But everyone's flow is different, so.
Yeah, and by the way, we have, just so you know, like, we can get it to your practices. We have these cards with QR codes for the app and all this swag. You know, you'll see thousands of people across the nation with the yellow clipboard in their hands and the water bottle and the bracelet. You know, on CNN, they're like, I wear my bracelet to remind me of the power of the protocol. So when we talk about how do you facilitate a movement and getting this in all hands, right, that I imagine this like the blue ribbon. We can send you hundreds of these things and get them out, you know, into the community as well and in your practices.
Thank you.
So that was actually part of my question, Dr. Posner, because when I see a child who is a victim of a suicide attempt that's in a very critical case, it's not like in the office, it's not in the pediatrician's office, because I'm not a pediatrician, I'm a pediatric anesthesiologist. And so if there is a resource that you and Dr. Hofstas have that we can give to people, either, not everyone's QR code savvy. Even I like a piece of paper every once in a while. And even if something is put up that, is signed and sanctioned by the Columbia Suicide Severity Scale, and maybe someone will scan it, or maybe someone will take a copy.
Exactly.
So if there's some sort of connection there, that'd be awesome
Yeah,
that we could send to our.
I'm so glad you said that, because some people will use the app. Some people need to take the card that's sitting on that you will give them when you go see them. And these things don't replace each other. They complement each other. So that's what we think, you paper the community with all these different ways to get the question. I'm so glad you said that, as I said. And all these different cards, ask your kids, ask your student, ask your athlete, right? Same questions, but just connecting to a different, in a different way.
Yeah, hi. It was a beautiful presentation. This is Agida Atkinson. I am a retired pediatrician. And I was curious to know, you say that the high prevalence of suicide in younger kids, how can you tell us a little bit, how do you use this for a 6-year-old kid?
Yeah, you use it the same way that you use it for anybody else. I don't know, you remember that data I showed you that in the ER, as an example, the 6 to 11-year-olds had the same odds of having high risk on the Columbia.
Right.
I said, so you ask it routinely, you normalize it the same way. So the way they do it in schools, in middle schools and even preschools, they can be using the questions, right? We want to get it in every parent's hands that are the parent of 5 and 6 and 7 and 8-year-olds. So we treat it the same way. Sometimes we have our own anxiety or stigma, like, oh, well, we have to think about this differently, right? But
no, I think my challenge is more, what wording? Can you give an example?
Absolutely.
The way you approach, because it's easy to ask a child, I would say 10 and up, but under 10, I feel honestly difficult to ask those questions, because I don't know how.
Yeah, my work started in like 4 to 6-year-olds, and a long time ago. And we have a screener that is for preteens, even though 6-year-olds have been using the regular one, but we now have an updated.
Oh, okay. You have it for different ages. Okay. Because I was looking to the regular one. I said, how can I ask those questions to a little kid? I don't know.
We're gonna add that to the resources, and
will be awesome, because we when I say the AP, we were involved with a behavior team, and then about the depression screening, and then we didn't have a screening. I know this is specific for suicide, but I think would be a very good thing that we could share with the team that is doing this project here in Delaware. And then I think I'd love to have those, or you can guide us, how can I get online all the different ages?
Yeah. And there's just really the two, and
just the two. Good.
And there's wonderful, wonderful different deliveries of it. There's an electronic self-report system that you can, put into your practice, as well as the little card. And I would love to help you get that into kind of policy, which policy drives impact, right? So just like I showed you in Connecticut, how they legislate in schools, policy drives impact. And I would love to do that. And the way, we were talking about this yesterday with a peer, or when you're, how do you tell a little kid about these questions? Sometimes your friends, when they don't feel well, they get some medicine, or they have an infection, they go to their doctor. Well, sometimes, it's pretty common that kids feel sad. Also, that's another thing that can happen. And they need some help when that happens, so, the language to talk to your youth, but the specific questions, the routine questions, we will get you right away.
And I think
Awesome.
just
Thank
to
you.
piggyback on that, Dr. Atkinson, like, you know, as you raise, like, gosh, little kids hear about death all the time. If we think of Pixar and Disney and just, you know, Avenger, all the like popular content, like death is all around them, right? And so I think to echo the point of specifically asking, but I think some words like, you know, have you ever thought about going to sleep and not waking up, or being unalive, or you know, dead? Kids hear about that, and I think when, you know, sometimes the beauty of real little kids is when they don't understand, they say, "What are you talking about?" And we can kind of go a bit further, but I think kind of phrases, you know, like that could be
Yeah, and Katie, those are the words from the Columbia, the what, right? The ones that you just said. I don't know, Samantha, if you could actually bring up the youth screen, the preteen screen. I'm gonna get out of here just in case you can. But those are exactly the words that, you know, they're tailored, right? A kid, you know, a little kid won't think of,
Oh, okay.
right?
Oh, this
You know,
is wonderful. Yes,
instead of saying
yes.
intent, it's like, is this something you might do? And all the experts, you know, there are lots and lots of suicide experts that are authors on the Columbia. And we did yeoman's work in kind of, you know, customizing the script for the different
Just
age.
to interject really quickly, and a shameless plug for the Delaware AAP Spring Conference that's going to be coming up this April. You know, there is a big component about it which will be around mental health, and it's going to be in person. And I know Dr. Poser and I had talked about her coming down potentially and being a part of that and having these resources available. So for those who want more information and are really trying to figure out how to get not even just within their practice, but beyond, just think about coming to the conference as well, in addition to accessing the resources that are being presented here. And as part of the Justice, Equity, Diversity, Inclusion Committee, this is something that our team thought we need to get this out there. And so, and Delaware AAP will do even more with that come April. So just a shameless plug there. And I know we're at
Oh,
1:37.
Oh, we love that. Yes. Yes. It's our call to action, and we're very grateful for you to be here today and hopefully to partner with us. And I'm very grateful to you, you know, for setting this up.
It's
yeah.
my pleasure.
Wonderful.
And
Thank you.
Dr. Deb, do you have any, I know Dr. Reichart was on the call. He might have had to go back to clinic. He's our president for the Delaware AAP. But Dr. Deb, do you have any final words for the webinar?
No, I will say, Dr. Posner, first time I think I have seen the CCRS was in Grand Canyon. Okay. So, and then I noticed in everywhere in like over Denver area, a lot of things have it. Their buses also even have it. Actually, the public
Really?
buses,
Really?
yeah.
Really?
Yeah,
Oh,
but
that's
some of the
awesome.
seats behind the seats of public buses have it too. So yeah, and obviously in New York, I have seen that. So, but like it's using as practical. So while I was thinking, I had a question for you. So you showed that we can use those card with our brand tag on it going to the marketing. So like if we have the card and we ask through our marketing, anyone can put their institute
Absolutely.
and do that, right?
Absolutely. Absolutely.
Mhm.
And for your workforce or whatever, you know, and so now in Pennsylvania, it's, I mean, it's about to go for the entire workforce, right? Those are the things, again, that we can really
Yes. So
customize. And by the way,
I think I'm gonna take a thing on that like we are going to get it through our institute, because that's how every flyer has to come through a corporate institute. You
Yep.
definitely understand that, like, you know, so.
And I would say that also, whether you're a state or an organization, we work all the time with the app people to customize it. So Cleveland has done it now, so it connects to their EAP. The state of Pennsylvania, if you're a citizen, it will immediately connect to local resources. So we should work with, you know, with
Yeah. And getting in our app development is also too much into like all those. So like probably as an app education or app questionnaire, we can use that. So we'll definitely use this resource, and it was amazing. And Dr. Hopsis, thank you. well, you were having the trouble. So me and Dr. Hopsis, technically we share offices. So, so I was actually running in her office. Is she presenting from her office? Like, no, she's not. So, okay. Thank you both of you. And it was really enlightening.
Thank you, everyone.
Thank you.
Awesome. Thank you. Thank you again, Katie.
Thank
And
you.
thanks. Bye-bye.
Bye, everyone.